Good afternoon. I'd like to welcome you to today's Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities here in the School of Medicine, and we're delighted to bring you these weekly programs on medicine and society. What if there were a vaccine that could prevent cancer? Well, there is. Indeed, a vaccine targeted to several strains of the ubiquitous human papillomavirus, otherwise known as HPV. This vaccine has been available and in use since 2006. When administered in adolescence and young adulthood, especially, the vaccine guards against cancers, several of them lethal, caused by several types of HPV. With reference to this powerful preventive tool, we've titled this Medical Center Hour, Taking a Shot at HPV and Cancer. In this hour, we'll explore the sociopolitical context of HPV vaccination in Virginia and beyond. We're going to use clips from the 2014 documentary film called Someone You Love, the HPV Epidemic. And we're going to draw on the expertise of a panel of persons whose work in medical science, clinical care, and prevention circles around HPV. We're going to draw on their expertise as they discuss the importance of HPV vaccination for boys as well as girls. And they're going to talk as well about concerns that still limit the use of the HPV vaccination. Our panel is actually going to be moderated today by Emma Mitchell, who's here on my immediate right, Assistant Professor of Nursing and Co-Director of Global Initiatives in the School of Nursing here at UVA. Seated next to her is Mark Stoller, who's Professor Emeritus of Pathology and Clinical Gynecology here at UVA. Next to him is Emily Young, a community-based family physician who also works at UVA Student Health. And on my far right, Kari Ring, an assistant professor of gynecologic oncology in the Department of OBGYN, and also affiliated with the Cancer Center here at UVA. We're doing this program in partnership with the Cancer Center, and I'd like to thank all of them in advance. We'll thank them at the end, and we will also have time at the end for your comments and questions. I should also mention that Drs. Ring, Young, and Mitchell declared no financial conflict. Dr. Stoller disclosed that he does continue to serve as a consultant for Merck, one of the pharmaceutical companies that developed and manufactures an HPV vaccine. So I will turn things over to Emma Mitchell and our panel for taking a shot at HPV and cancer. Welcome.
Thank you. Thank you so much. And thank you, everyone, for joining us today for this really important topic. I'd like to also thank some of the organizers for this event, many of whom sit with us on a statewide task force. Increasing HPV vaccination is a statewide priority here in Virginia. We were the first state to introduce legislation requiring sixth-grade girls to be vaccinated, but the ease with which parents can opt out, combined with the misinformation circulating about HPV vaccination, means that we in Virginia still lag in vaccine initiation and completion. To center our discussion today on the importance of preventing HPV-associated cancers and diseases through vaccination, we're going to show a series of clips from the CDC-produced film, Someone You Love. The film focuses on cervical cancer prevention, but after we show it, we will also discuss prevention of oropharyngeal and other types of HPV-associated cancers and diseases with our panelists. Last evening, we had our second annual screening of the entire film, which shows the stories of 5 women and their experiences with cervical cancer. So we'll share a shortened version of the film threaded throughout our panel discussion today. We have some prearranged questions and discussion points we'd like to share with you, and then we'll open up for discussion and questions at the end. So we'll begin with our first film clip now. Thank you. Thank you. So I'd like to begin by asking Dr. Stoller, can you describe a little bit more about what it means for HPV to be ubiquitous and what the subsequent health conditions are that people can experience after contracting it?
Sure, Emma. Thank you. Is it on now? It's on. Okay. There it is. All right, so I should also add to my disclosure, I'm not just a consultant to Merck. I was part of the clinical trials that are ongoing that led to the approval of both of Merck's HPV vaccines. So with that disclosure, this idea that HPV is ubiquitous, so there are over 200 types of HPV, and every one of us have multiple types in various locations on our skin. Of the 200 types, maybe 40 or 50 types are sexually transmitted. The rest are transmitted by close contact, best we can tell. Of the 50 types that are sexually transmitted, we test for, when we do screening, 14 types. And 7 of those 14 types cause more than 90% of the cancers that we are going to talk about. And those 7 types are in the current Gardasil 9 vaccine, the 7 high-risk types that are associated with cancer, and HPV 6 and 11 that are associated with genital warts. So that gives you an idea of how ubiquitous and how common HPVs are. If we were to screen the women in the general population, as we do every day when they come in for pap testing and or co-testing, we're going to talk about screening. Roughly 10% of the women at any given time are positive. So this is a very common infection. And that's positive looking for only the 14 of the 200 and something types that we're talking about. Now, briefly, in terms of cancer, everybody knows about cervical cancer. Cervical cancer, we screen for cervical cancer. We've been doing it for 60 years, primarily with pap smears. We started doing it because everybody knew somebody who had cervical cancer. If you go back 50 years ago, cervical cancer was probably the #1 cancer in women, and it still is number 2 or 3 in terms of worldwide cancer incidence, more common than all the other cancers combined. But the effects of screening in the United States have led to the following situation. So today, we have about 12,000, 13,000 cancers in women picked up in the United States, cervical cancers, and about 3,500 deaths. More than 2/3 of those cancers are in women who've never been screened. Screening is incredibly protective, as we'll talk about it. So if you take the 12 or 13,000 cervical cancers and you say, well, what about men? Men have actually more cancers due to HPV than women have cervical cancers. And that's because we can't screen for oropharyngeal cancers. There's about 18,000 oropharyngeal cancers a year in the United States that occur in a specific area within the throat, mostly around the area of the tonsil and the back of the tongue. 15,000 of those are in men, 3,000 of those are in women. So there's more oropharyngeal cancer that's due to HPV in men than there are cervical cancers in women because of the effect of screening. What other cancers are there that we can talk about? Anal cancer, penile cancer, vulvar cancer, vaginal cancer. If you add them all up, women still get more HPV-related cancer than men, but both sexes are equally at risk. And that's why when we talk about vaccination, at least, we should talk about equality of medical access and prevention for both men and women. So to summarize, about 45,000 cancers occur in the United States a year in men and women due to HPV. What if we could make it 4,500? 45,000 cancers, if you just talk about cervical cancers, 3,500 cancers a year sounds abstract. Let's make it more concrete. 10 women a day die of cervical cancer despite 60 years of screening as hard and as best as we can. What if we could make it 1 woman a day instead of 10 women a day? Notice I'm not saying 0. You know, perfection is the enemy of good. But if we could take out 90% of the HPV-related cancers, it would do more for cancer prevention than everything else we do in cancer in one fell swoop. And with that, I think we can continue.
Thank you. We'll do our second clip now. Thank you. Thank you. So we heard about some of the barriers that people and patients experience to screening, but when it comes to vaccination, Dr. Young, I'd like to ask you, in your practice, what are some of the barriers that you see your patients and parents have, and how do you approach conversations about the stigma associated with HPV vaccination?
Yes. Is this on? Okay. So I'm a family doctor, and I see everyone, 0 to 101, I think, is my oldest patient. And I primarily focus on a lot of pediatrics as well as women's health. And the biggest barrier that I see is kind of continuing to result from that time when the HPV vaccine first came out, and there was a big rush of excitement about, well, if we give this vaccine, then we're encouraging our kids to have sex. The biggest thing that I do to counteract this is pull out the sex talk and the kind of concern about their kids having sex from talking about the vaccine and normalize giving the vaccine to them. So the vaccine for kids is due anywhere from 9 to 26 years old for men and or males and females, and recommended by the ACIP to be given at 11 to 12 years old. And this is at the same time as we give the tetanus and pertussis and diphtheria vaccine or booster, as well as the meningococcal vaccine. So there was a study done at UNC Chapel Hill that identified what would be the most effective way for providers to talk to their patients about these vaccines and increase the vaccination rate. The main outcome was that short, direct, and brief is the best way to overcome those barriers. Doing a lengthy conversation and talking about sex at the same time, which can be a very, very difficult conversation when you're talking about a 9 to 12-year-old. Avoiding or pulling out that conversation from the vaccines is going to be kind of important in order to make sure that our vaccination rates increase. And then lastly, training providers to do this direct conversation is important instead of just a placebo of not doing any training. So the way that I approach it is that, hey, Johnny is now of the age where he's 11 to 12. We have 3 vaccines available for you today in your well child check, or if they're coming in for a sick visit where they don't have a fever. I introduced that he's due for a Tdap booster, as well as the HPV vaccine, which is the vaccine out there that prevents cancer and the only one that we have that prevents cancer. And then he's due for the meningococcal vaccine, which prevents a really serious neurological infection if it happens. Do those vaccines sound okay to you? And most of the time, parents are completely perfect with that. They see this as another vaccine. It is just another vaccine. It's a very important one for this kid and these people's futures. And kind of making sure that they understand that it's just as important as the other ones and shouldn't be more scary because it doesn't have any increase in side effects. The side effects are the same as the other vaccines, essentially. A little bit of redness and pain in the muscle, maybe a little bit of some feeling kind of crappy afterwards, because that's, the immunological response turning on in our body is making us feel kind of crappy that day, and it's not really anything that some ibuprofen can't help. And I think parents are reassured to hear that. So I do have the sex talk, obviously, very honestly with patients, but I just don't think that it should be tied to the HPV vaccine. It's a really complicated idea for people to grasp that you have this virus, you can catch it at some point, you will catch it in a sexually transmitted way at some point. It's transient or ubiquitous. Almost everybody gets it. It usually goes away by 30, but if it persists, then we have to watch it a little bit more closely. And if it does persist, it can cause cancers of certain areas of the body. That obviously is a very stepwise idea that you start off at one point and it causes this, and then it causes this, and it causes this. But we have a vaccine that prevents that whole pathway. It's a complicated and convoluted thing to explain to people who don't understand or are lay people in science, essentially. So just talking about the vaccine as it's the only one that we have that prevents cancer, that is the main message that we've transitioned to talking about in the primary care setting, and it's been working.
Great, thank you so much. I think that helping to reframe the narrative, as you're saying, against those misconceptions and giving providers the tools to have those frank, direct conversations, as you suggested, are really important. Can you or our other panelists speak to a little bit of the other types of barriers that people experience in vaccinating, other than stigma or misconceptions?
Well, I'd like to just make a comment on what Emily said, which is this relationship between giving the vaccine and stimulating sexual activity per se, because there are now nothing like a little data, right? But there are multiple studies that have looked at this from a sociological or behavioral aspect, and not a single one has shown that giving them the HPV vaccine increases sexual behavior. Quite the contrary, it makes them more aware of their own sexuality and maybe more careful in considering it. So it's a great example of the difference between perception and science, or perception and data. From my standpoint, having been there when it was approved in 2006 and seen the incredibly slow uptake in the U.S. relative to the rest of the world, I mean, to me, the barriers are that our health system doesn't promote organized vaccination. I mean, if you go to Australia, if you go to England, it's recommended for 6th grade kids. Well, you show up for the 6th grade, you get your first shot, you get your second shot at Thanksgiving, and your third shot at spring break. And then that's the way it is, and they have you at school, and no problem, and everybody accepts it. That's a far cry from what we do here in the U.S., but I would strongly agree that normalizing the conversation is the key to success, and I think there's good data showing, study after study, that in practices, pediatric practices and family practices, you the guys who've given the vaccines at the right target age, that's what you got to do.
I think it's also, it's helped us a little bit in that there's now data that's come out that if you get your vaccines before the age of 14, you actually only need 2 shots instead of 3 shots. So not only is it's a stopgate where we're giving other vaccines, but I say to parents, and unfortunately I'm seeing patients usually on the other end of the spectrum that have gotten cancer, but that doesn't mean that I don't get on my soapbox with their families during their visit, is that they only have to get 2 shots instead of 3 shots if you give it to them at the recommended age. And so I think that has helped us a little bit.
And just to kind of piggyback off that, my main thing is that when I see a kid, I'm advocating for who they are as an adult and when I will see them in the clinic. And to think back, if they are now coming in at 21 years old and their parents chose them not to give them the vaccine at 11 to 12 years old, I almost think that's not fair, that they didn't get it. They didn't have that ability to make their own choice against not being or preventing cancer for themselves. So I think about what their choice would be when they hit that 21-year age or even 50-year age. And it's like, well, was that fair to them to have that ability to prevent cancer taken away from them? And the answer is no. So that my job is to make sure that the parents understand what this means to their kid later on. And if they leave the office not understanding, then that's my fault. That's not theirs, that's mine. And the reason that the 11 to 12-year-old is so important to give is not only because it reduces the barrier of only doing 2 shots instead of 3, but it's an increased immunological response at 11 to 12 years old, and that's why we give it at that age. It's approved down to 9 years old, which is awesome, and we give it as early as 9, but the 11 to 12-year-old age group is where that immunological response is so high. If they wait until they can make their own decisions at 18 or 21, that immunological response is decreased, still effective, but decreased. And if their parents choose not to give it to them at the 11, 12 years old, they're missing that immunological response.
Thank you. That is really the emphasis of where we try to aim our prevention efforts. Dr. Stoller likes to say, screen the mom and vaccinate the kid. But very recently, we've had the FDA approve an extended age period for the recommendation for HPV vaccination. It will take some time before the ACIP approves that. But Dr. Stoller, can you talk a little bit about what that means and how that will impact our patients?
So, I mean, the expansion of the age range up to age 45 now, I look at as a major advance because the end goal is to decrease the prevalence of the virus in the population. The faster you do that, the faster we start seeing the downstream effects: no genital warts, no abnormal pap smears, no biopsies, no surgeries, and ultimately no cancers. And so that was the rationale. The reason it wasn't originally that range was the idea that sexually active individuals, are already exposed to the viruses, and the virus and the vaccine is prophylactic. If you've been infected with HPV-16, the virus that causes 50% of cervical cancer, you're not going to get any benefit from an HPV-16 component in the vaccine. But that being said, we now have much better epidemiologic data, and for the average 35 or 40-year-old, now that we have a vaccine that has 9 viral types, the probability that you're going to be exposed to all 9, even if you have a happy and healthy sex life, less than 1%. So for every virus that you haven't been exposed for, and it's sort of a Russian roulette kind of experience, if you will, for everyone you haven't been exposed for, the vaccine is perfectly effective. There was one other comment about barriers versus benefits. There are 3 HPV vaccines in existence. The 2 from Merck, Gardasil 9 now replacing Gardasil. Gardasil had 4 viral proteins. Gardasil 9 has 9. And then there was Cervarix, the GSK vaccine, that had only 16 and 18. And I want to bring back to the concept of genital wart prevention. In England, they used to spend more money on genital warts in terms of total medical care than they did on cervical cancer, right? Genital warts, I'm not going to ask for a show of hands, right? But this is not a pleasant thing. And all I can say is that genital warts have disappeared in clinically vaccinated populations. So for instance, in Australia, where for the past 8 years, they started a couple years later than we did, 85, 90% of the population has been vaccinated. There are no genital warts clinically. I mean, you just don't see a case. You can't have a case to teach somebody what a genital wart looks like. They're gone. They're not only gone in the people who have been vaccinated, they're pretty much gone in the people who haven't been vaccinated. The concept of herd, for that last 10%, the concept of herd immunity is really well demonstrated. And so, if you wait till 21, I don't have to tell you how many cases of genital warts you see in people who haven't been vaccinated, but I guarantee you haven't seen a case in somebody who's gotten the shot.
Right.
Yeah. I think as far as, access to care, of course, we have the same issues with access to care as we have for all other immunizations. But I think another problem is that because we've done such a good job of screening for cervical cancer, not as many people either know someone who had cervical cancer or who have a family member who have cervical cancer. And so people just aren't talking about it as much. What I say to patients is, if there was a vaccine for breast cancer, that everybody would go get it. And it's true in that everyone has a loved one who had breast cancer or their family has been affected by a more common cancer like this. So I'm like, it's just like that. And when I say that, people are like, I would get a breast cancer vaccine. And I find that relating it to people that people know or their loved ones helps.
Thank you. Thank you. Let's see our final clip from someone you love. Thank you. Thank you. So we've mentioned Australia as a case study a few times. They've been in the headlines very recently as they're targeted to be on track for eradicating cervical cancer. And this is really accomplished through a combination of prevention strategies, most importantly vaccination, but additionally screening through innovative technologies and high quality follow-up. Closer to home, in September 2018, the USPSTF, the U.S. Preventative Services Task Force, issued a new set of guidelines for screening, and this will really continue to be important because our vaccination rates lag. So primarily, we want to promote vaccination, but screening's still necessary in that process. So Dr. Ring, can you talk a little bit about those screening recommendations applicable here?
Yeah, so the recommendations say that we should screen women aged 21 to 65 for cervical cancer, and there are three main ways that you can screen. One is with cytology alone, so that's the pap smear where we collect cells from the cervix at the time of a speculum exam. The second is co-testing, where we do both a pap smear as well as test for HPV strains through a PCR test, and we do them together at the same time. We send them off. And the last is HPV screening alone. We know that the risk for infection with HPV is highest in your teens and early 20s, and so between 21 and 30, we do cytology alone because that's the highest risk for someone to have a transient infection where we could see a positive HPV test but no changes sort of on the pap smear. Starting at 30, you can either do co-testing or you can do primary HPV screening. Great. And they're different time intervals. It's all.
So the complexity of the screening guidelines is sometimes a barrier, I think.
Yeah, I think most providers, and I can't speak for everyone in the community, but I think most people over 30 are still doing co-testing. But as Dr. Stoller has mentioned, there is a move towards HPV primary screening alone because that is probably the most predictive of downstream abnormal cytology going forward.
So let me make a comment, because every woman that's ever been screened or had a pap smear, for 50 years we told people, come in for your annual pap smear, right? And the annual pap smears were great, but we made up the interval. We never did a study. It just sounded good. You got to go to your doctor every year. Let's get a pap smear. So the current guidelines actually are backed up by epidemiology and science, and they recommend screening every 3 years with pap smears or every 5 years if you add in the HPV test. And the reason the intervals are different, and this makes it confusing, and it makes it seem like we're taking away something. In fact, there's a law in Virginia that says you're entitled to an annual pap smear, right? But you don't need an annual pap smear. I'm here to tell you, you don't need it, all right? And that doesn't mean you don't have to go see your doctor every year, but you don't need cervical cancer screening every year if you do a good test. And today, I'm also here to tell you that a good test means do an HPV test, right? Because all the power in screening is on the side of the HPV test. If you do the HPV test, the pap smear adds virtually nothing. And that's why I'm an advocate, and I've written some papers about primary screening versus co-testing. So I don't care if you do co-testing or primary screening, as long as you do the HPV component of the screen for women over 30, or eventually it'll be for women over 25, and we could talk about, 21 to 25, whether it's worth screening at all, perhaps in some different venue.
So just to add a further point, and please jump in to clarify, with PAP and cytology, the process that we're mentioning, a provider uses a speculum to collect cells to visualize for cancerous or precancerous cellular changes. With an HPV test, which is processed through PCR, as Dr. Ring said, we're actually looking for the presence of the DNA of the high-risk strains. So a primary HPV test would then tell you you have an increased risk for developing cervical cancer versus a PAP telling you we are visualizing cellular changes. And so one of the, as I mentioned, we will continue to need cervical screening and high-quality follow-up because of our lag in HPV vaccination. But one of the exciting things, too, are the innovative technologies that are being developed to try to increase access to screening for those who are underscreened or unscreened. And some of these include women being able to collect their own samples. So I have the pleasure of being here today because that's my area of research. We're looking at whether we can help women increase access to cervical cancer screening through HPV DNA testing with samples that they collect themselves. We have 2 studies looking at whether they can do this at home with a lay navigator or somebody similar helping them to explain the process, or in combination with mobile mammography. But the idea is that if you can do this primary HPV test, you can tell women what their risk is. And if they know what their risk then is of developing cervical cancer, it may help them to overcome some of the barriers that they experience with screening.
And one of the things that I think is important to focus on is that this is really for the age of 30 years old and over for women screening for HPV. And this was a kind of a convoluted idea that I had to spend some time understanding, that when we say that everybody or HPV is ubiquitous, we mean that teens and those in their 20s, almost everybody who is a teen or in their 20s will get some form of HPV. So they all have that infection. They might not have cervical change. So it's important to do pap smears to detect that cervical change, but we know that they probably have HPV. So we don't really need to screen for HPV when they're teens or 20s. We just need to look to see if there's cervical change or cell change to see if they're developing any signs of cancer. When they hit 30, at that point, HPV usually goes away by itself 9 out of 10 times between 8 months to 2 years. So most of the time, people who have HPV, regardless of the strain, might not know that they actually have it. It's asymptomatic. If they get to their 30s and they still have the HPV infection and it still is persistent or chronic, at that point, it might cause change to the cells on the cervix, and that can be precancerous or cancerous. And at that point, a persistent HPV infection correlates to your direct risk of having cervical cancer, and that's why we're focusing on that HPV screening in that age group of 30 to 65. So it really is, yes, everybody will have HPV early in their life. 9 out of 10 of them will get rid of it. 1 out of 10 of them won't get rid of it. They can have HPV and not have cancer. 1% of that whole group of people who have had HPV will probably develop a cancer of some sort, head or neck or genital. So it's a small amount, but because everybody has it at some point, and this is millions of people, almost 80 million people that have it at one point, because so many people have it, that still is even 1% chunk of HPV causing cancer. That's a huge number of people getting cancer. Besides HIV, HPV is the most fatal virus out there because it kills. So, and the reason is because it's so common.
Comment? So let me help your thinking. You did terrific. You've been listening, all right? But I think a couple extra comments are in order, because the HPV, it's a common misconception about what the HPV test is and isn't, right? So if you come in and say, give me an HPV test as part of my cervical cancer screening, and you're HPV negative, doesn't mean you don't have HPV. Doesn't even mean you don't have the HPVs that we're testing for. The test has been engineered, and this is why it takes, we're talking $30 to $40 million trials to bring an HPV test to market in the United States. Tests are engineered not to detect absolute HPV positive or negative. The tests are engineered to detect the level of those 14 viruses that predicts cervical cancer risk. And that's where people sort of don't understand what's going on. So in some future, this age distinction is going to go away. It's not that you can't use an HPV test in 25-year-old women. It's that how you respond to the HPV test in a 25-year-old or a 21-year-old is different than a 30-year-old. In a 30-year-old, if you're HPV 16 positive, you're going to go to colposcopy and see Dr. Ring for biopsies. If you're 21, maybe you have to be positive a couple of times. So that's an important point about the test is really a test for cancer risk, not a test for HPV. The other thing is that when you're positive, remember I said 30-year-old women, 10% of them are going to be positive. Well, we don't want to send all 10% of them for advanced visualization and biopsy. So nobody who gets a primary HPV test just gets that test. Then they get a reflex test to figure out if they really need to go to colposcopy. That current test is cytology, but there are even better tests coming down on the market.
I think another important point is we know that there are some populations that are higher risk for persistent HPV infections, right? So people who are chronically immunocompromised, people with HIV. But for a large majority of the population, and there's lots of science going on trying to figure this out, we don't understand why it is persistent in some patients versus others. And so I think that's another important point for people and patients to understand is that yes, for most people it's cleared, but we don't understand for the majority of people why it is persistent in some patients, and that's why follow-up is so important.
It also is why it brings us back to the importance of vaccination. That primary prevention through vaccination is really our strongest tool. So maybe if we could each say just a couple brief moments about the takeaway message of the importance of vaccination, and then we can open it up for some questions. Do you want to start, Dr. Stover?
Sure. So my message is consistent. Screen the moms, vaccinate the kids. But now we can screen and vaccinate the moms and vaccinate the kids. Because this is one example where more is better. The more vaccine we get into people, the faster we lower the prevalence of disease. The other important point about vaccination, they brought up briefly that they're having this eradication of cancer conversation in Australia. Well, it's not going to zero, right? But if we were to vaccinate the population the way it should be, right? That within 10 years, and Australia's been doing it to 10 years, between 10 and 20 years, you drive the prevalence low enough that screening doesn't work. Remember all the other cancers I talked about, vulvar cancer, penile cancer, anal cancer, head and neck cancer? We can't screen for them because those 15,000 cases sounds like a lot, but if we weren't screening, if we hadn't done pap smear screening, there'd be 100,000 cases of cervical cancer. That's why everybody knew about it. And below a certain prevalence in the population, screening doesn't work. So they're really talking about the end of screening, and that's the goal here. Doesn't mean all the cancers will go away, but there'll be so few cancers that we can't sustain a screening program. And in that transition, we're going to need better tests like the HPV test.
My main point is that this is another vaccine that is recommended as safe and effective, just as the other vaccines that we give for 11 and 12 years old, as well as other vaccines later on in life. So it's a normal vaccine. It is safe and effective. The risky choice is to not choose it. The risky choice is, or the safe choice is to choose it for our kids.
I stick to it's a cancer prevention vaccine. That's strictly what it is. And I tell people I would love to be out of a job as far as cervical cancer goes.
Great. Thank you. Thank you all so much. So we've talked about how misinformation is such a barrier to people vaccinating, and our goal here today was to give you data, give you some strategies, and give you some real information about the importance of the vaccine, the safety of the vaccine, and how we will watch as the age of the vaccine recommendation rolls out into clinical practice, but as we continue to advocate for it. So thank you so much. I think we'll open it up a little bit for some questions from the audience.
Thank you all. You've raised a lot of good points, offered a lot of information. We have an audience with members from a variety of disciplinary pathways, and so we have a nice opportunity for people to offer comments, ask further questions, and just generally consider both the issues of screening and vaccination for HPV. We have a couple people with microphones. They will bring the mic to you if you have a question or comment, and we do ask, please, that you identify yourself before you ask your question or offer your comment.
Hi, I'm Bridget Therese. I'm an M1 here. And I was wondering if you know what the thoughts are on whether the population that received Gardasil 4, like was young enough for that, but then it's going to age up, will be recommended to receive Gardasil 9.
Go ahead.
So currently, ACIP, or the main body that recommends immunization guidelines to the director of the CDC, who then adopts them as the main guidelines in the United States, they say that if you did receive the Gardasil that has the quadrivalent or the bivalent, so the 4 proteins or the 2 proteins, that you can continue on and get the last shot. So say you got 2 shots of one of those, you can get the 3rd shot using the Gardasil 9, and you can continue on that series of getting the 3 shots without thinking that, oh, you need to restart it. There is some evidence that the additional 5 HPV strains that are present in the Gardasil 9 give you extra benefit in protecting you against extra cancers, specifically head and neck cancers. So some people are saying that, yes, maybe you should go ahead and get the 3 vaccines over again, but there is no data to recommend that. And the ACIP currently says that if you had 3 or 2 shots of the other, or 3 shots of the other 2 vaccines, you're done and you're protected against the main goal, which is preventing the majority of cancers.
So it's a 20% incremental benefit, right? So if you're fully vaccinated with Gardasil, right, nobody's going to pay for a Gardasil 9 series for you. If you want to, on the other hand, the data exists that it's safe to give it, right? You're not going to get, so if you wanted that 20% extra benefit and wanted to pay for the 3 shots, it's not going to hurt you, but it's really a marginal benefit. Now, as was said, if you've started the vaccine, so there were people, Gardasil 9's only been on the market for a year or so, if you've got your first shot with Gardasil, you can finish with Gardasil 9. That also works terrific. So that's the current status.
Hi, I'm Miriam Bender. I'm the chair of Women's Health Virginia, and I have a question about clinical practice and behavior. We've seen evidence that direct communication that Emily referred to is the most effective thing, and CDC has a program called You Are the Key, meaning provided you are the key to communicating. But we also have heard that many providers haven't really gotten that message and don't take the initiative to say to the patient or the patient's parent, this is a cancer prevention, it's part of the routine vaccines. They still give the patient, parent, a choice and say, well, do you want Susie to get the vaccine today? And when mom says, no, the doctor says, oh, okay, we can do it next year or whenever. The other thing is that practices don't seem to be ready to change with a system so that you get callbacks, so that even with initiation, you don't get completion of the series. And I'd like your advice or opinions for the audience and for myself about how we can best get practitioners to move to that next step. In the initial round, it seemed pediatricians were doing better than family practitioners, but it still is a challenge across the board.
It's like a whole public health. Well, I hear you. I would echo your concerns. As a GYN oncologist, like I said, I'm on the back end of this, and so there's a large volume of work going on in the GYN oncology community to try to, increase awareness to this, education campaigns to primary care providers, because unfortunately, while all of us GYN oncologists feel very passionate about it, we have to get it into the primary care system. So I think there's a lot of education campaigns going on throughout different communities, not just to the primary care physicians, but to different socioeconomic groups. One of our fellows is actually working on that and trying how to access sort of communities and social networks to see how we can better educate them. Because it's true that when advice comes from someone in your sort of socioeconomic group, people tend to pick up on it more. So there's lots of, I think, education and research going on around that. I think that's a huge problem, and part of the reason that we're where we are as sort of vaccination rates go. I think as far as completing vaccinations is also a big concern. I think that's where it's also helpful to push it in the 11 to 12 age range, because again, you only need 2 rounds, so you have a higher completion rate. And so I think that's where it's important to emphasize that.
I definitely hear you that we need to increase how strongly providers recommend this. And that's one of the points of research is that providers just aren't recommending it as strongly as they need to. My method is that, when, as a family doctor, building rapport with my patients is really important. And so a lot of times I know the patients really well. By the time we're talking about HPV vaccine, I use a lot of humor in my visits. And so it's more of a, not a recommendation, but you're going to get this today kind of thing.
Congratulations.
It's the way to do it. It's the way to do it.
And oh wait, you don't want it? No, you want this. You're gonna get it today. Wait, no, you don't want to get it? No, you're gonna get it today again. so it's definitely a difference in the strength of the recommendation from when I was educated in medical school or residency, because we did at that time think about HPV vaccination as a really hot button or controversial topic, and it shouldn't be. It's not about sex. It's a vaccine to prevent cancer. It's not going to cause sex. And so, but your kids are going to have sex anyway, so hopefully as healthy adults. So, but we won't go there yet.
So there's another way to increase compliance, and that's through the payment system.
Yep.
So it's actually already a quality assurance measure in many practices, a HEDIS measure, right? I mean, pediatricians are measured on how compliant, big thing that pediatricians do is vaccinate, right? It's the biggest thing they do, probably from my standpoint. And, what percentage of your practice is getting HPV vaccination? Why are you not? You could make cancer screening better too if you made people comply with guidelines in terms of doing co-testing or HPV testing and doing them at the right intervals. So that, I think, is coming, where, you're not going to get paid as much by the insurers, or you're not going to get paid at all unless the kid gets a vaccine. So
I make them, or I don't make anybody do anything, but I ask them to put a reminder in their phone for when the next ones are due. So either the patient themselves or the parents, so that kind of gives them a little bit more agency. I also write it on their after visit summary, wherever else they can write it down. And then I write it down in my charting system too, so that next time I see them, that, even if they got it at 11, if the next time they come back is at 16 because they want to get another meningococcal shot, at that point I can say, okay, we need to do HPV number 2, because we do try to give it at appropriate intervals, but if that interval is interrupted for any reason or prolonged, we can still continue the series and give it sequentially, so we don't have to restart. So if I do see them again for the meningococcal vaccine or a sick visit or college physical or sports physical, at that time I can be flagged to give it again. But we do need better systems of how to flag providers to strongly recommend it.
Hi, I'm Rebecca. I'm a public health and bioethics student. So outside of this whole idea that the HPV vaccine promotes sexual promiscuity, do you guys see the national narrative of the anti-vaxxer movement affecting this at all, or is that something that's just not really in focus as much?
I think it is. I think it absolutely is. And I think that the anti-vaxxer movement has had taken a lot of hold in social media, which we know has been research specific to the HPV vaccine, and has been found to influence people's perceptions. We did a little analysis of the sentiment of tweets over a course of a 2-week period, and in the School of Nursing we did this research, and we found that the most often people were retweeting opinions and not the position statements or policies of recommendations and organizations. And so I certainly think that the anti-vaxxer movement is influencing and is part of what we need to be doing in changing the narrative. Dr. Stoller?
This is a war. It's a war, right? The anti-vax, I would not minimize, we didn't bring it up because it's a very complex topic. As a student, I encourage you to figure this out. But the
Small project,
anti-vaccine
one-year
movement,
project.
The anti-vaccine movement has had a tremendous negative effect on the health of the population. It's not just the HPV vaccine. I mean, you just put in the word vaccine in the New York Times, and, you know, there's an article about measles and mumps, and we have an epidemic of diseases that nobody's seen in the last 20 years because of the anti-vaccine movement. In Japan, the anti-vaccine disinformation program has led to a cessation of HPV vaccination. So Japan will be, it's not that they don't have HPV, and they certainly have cervical cancer, and, you know, for whatever years that they stop vaccinating, they'll be that far behind the rest of the world in bringing these cancers under control. So it's a huge problem, and it's really, you know, data and science and good information versus bad. How do you get that out into the population of non-scientists?
These people are scary, and not just in the sense that, you know, they're causing a huge public health issue, but they scare people. I mean, I brought my son in for his MMR, and I'm an evidence-based doctor, and even with getting the MMR shot, I was like, oh my gosh, is he gonna get autism? And just because they scared the poop out of me already. So, and it wouldn't be a bad thing if he had autism, because it's another kind of person, it's another kind of normal. But they scare us so much with their force that's what parents hear and envelop. And even if they aren't people who are anti-vaccines, they still come in with questions because people have scared them or the community has scared them. And so those people who come in, or parents or patients who come in with fear, they're easy to kind of transition into the fact-based idea that the vaccine is safe and effective. There are people then in the second category who come in who accept all other vaccines but are wary of the HPV vaccine for whatever reason. And they're also easy to transition into that idea that it's safe and effective and we can go ahead and give it today, or maybe at next visit after I give them information and they go home and they read about that information themselves and then make their decision. That third category of people who are completely against vaccines, I'm almost never successful in transitioning them into getting the HPV vaccine because they are so thoroughly engrossed in their idea that it's going to cause something bad in the body. And so they're the group that I think is the ones that are propelling this public health crisis forward. And I haven't been successful in reaching them.
So I got to say, our first line of defense against anti-vax, and I am the mother of an autistic child, so I speak with conviction. Our first line of defense is the primary care physician, okay? You're the one that has the relationship with the patient. You're the one that has to change their mind. You're the one that has to put forward the data. You're the one that has to make a difference, okay? And it's critical. I mean, it just can't be that we allow people to walk out of the office and not go ahead and at least make up that follow-up appointment and say, really, this is so important, I really just want to make another follow-up appointment just to talk to you about it again. Even if they're absolutely against it, let me give you this data, okay? And let's make a follow-up in a couple of weeks and talk about it again. I just think it's that important. When this came out, I have 4 kids. I couldn't get them there fast enough, okay? And the people that want to make this about sex, fine. Don't tell me that you don't want your kids to ever have sex. That would be a lousy life, okay? We want our children to eventually procreate and have wonderful lives, and this protects them and allows them to be there for their children someday. These are the things we have to put forward, and these are the things we have to convince the population, and that peer pressure has to be against the anti-vax group. Okay, there has to be more pressure against that than there is for it. Okay, enough said.
Agreed.
Agreed.
Yeah.
We have time for maybe one more question or comment.
I'm Sarah Yoder. I'm a physical therapist. I work at the Cancer Center, and I work with some of our head and neck patients. So that being said, I'm kind of curious. You mentioned Australia and cervical cancer outcomes. What about head and neck outcomes? Is there any data associated in Australia with that?
Too early.
Yeah.
It's too early because there is no screening, and you get these people are getting infected, in their teens and 20s, and then they're showing up with cancer in their late 20s and 30s and 40s. So it's too early. And I should add that the label for these vaccines doesn't say anything about head and neck cancer. It's because there's no screening, because where these cancers develop are not amenable to pathology samples. There have been no clinical trials for head and neck cancer. But as your friendly neighborhood pathologist, I'm here to tell you that head and neck cancer due to HPV is exactly the same biology and pathogenesis as all the other HPV-related cancers. So there's absolutely no reason from anything we know scientifically that HPV vaccination will put it in the positive. HPV vaccination, from everything we know scientifically, will absolutely help prevent head and neck cancer, which is a horrendous, as you know, every day, is a horrendous experience for the patient.
Great. Well, I'd like to thank our friendly neighborhood pathologist and our other, and it's lovely to offer a program with such generous local expertise. We're really grateful for this conversation, which interestingly reminds me that in, I think, 2006 or 7, we actually did a medical center hour about HPV when it was first new, and a great deal of that debate was around the ethical questions of whether it was appropriate for the state to mandate a vaccine for one sex but not the other. At that point, the recommendation was only for girls. So we can see we've come a ways. There's a lot more data. There's a lot more information, and there are a lot more people who are using the kind of conversation script that Dr. Young is using with patients. So I'd like to thank all of our panelists and for you for being here. I encourage you to come back. Next week, we have a program called Lola's Song, A Family's Journey of Change and Healthcare Transformation After Medical Error. It's our annual Richardson Memorial Lecture, which examines issues in the sometimes uncomfortable area of medical error and patient safety. So we'll be here next Wednesday, same time, same place. And again, please thank our panelists for today.